Perfect. And we are actually almost at time, so I think there's room for one more question, which is a very interesting question, and I wanted to open up to any and all of you speakers. When is it a good time to have your case discussed in a tumor board? Um, Very general question. Do you guys have any thoughts about that? I'll
Mm,
start. So, I think that maybe taking a step back about what this question is, what a tumor board is really an opinion from a group of physicians, and you could consider it as a second opinion in some sense. So I think it's always an okay idea to have your case reviewed as a second opinion from a consultation from a different institution. I always recommend second opinions for my patients so that they feel confident in number one, their diagnosis and treatment plans. Also, they may have preferences that a different institution may align with. So, in my opinion, the heart of this question may be about second opinions. I always welcome it. In terms of tumor board, I think it's very challenging from a patient's perspective to either join a tumor board or contribute their patient case to a tumor board. These are typically physician run and a confidential discussion between specialists so that they can understand the context very quickly and talk about treatment decisions as a multidisciplinary group. I think it's always okay to ask your physician if you think your case is appropriate for a tumor board if one tumor board exists at that institution. But it's hard to prescribe a single instance or a single paradigm that says this is the type that goes to a tumor board. That's my opinion.
yeah, great. Thanks. And like that's what I usually do. Is that usually your physician determines when the case needs to be presented on tumor board. I usually present it when I'm not certain about the diagnosis. So I don't know if you guys know how our workflow goes, right? Like when I get a consultation, they send me a piece of paper with pathology diagnosis on the top, and then what are the stain they do. So sometimes when you look at the stain, you're a little confused in terms of, the patient's clinical presentation does not match the diagnosis. Then you have a tumor board where your pathologist shows you the slides, the radiologist shows the PET scan, everybody look at it, and then we'll hopefully reach to a diagnosis. If we don't reach a diagnosis, we can talk about what tests we do. And then like Andrew said, it's kind of like tumor board has all the physicians with that department that joins, or all the lymphoma doctors at Moffitt. So I can ask my mentor or other doctors, well, what would you do in this case? And you also have radiation oncologists, and then also our beautiful, amazing BMT doctors. So a lot of case we'll talk about allo, right? The For us, we're like, oh, patient goes to allo because we get a cure, this and that. But your transplant doctor might say, oh, the risk of allo is too high. Is heart issues or this issues or a lot of issues that lymphoma doctor don't think of. Sometimes there might be even a debate, but eventually we reach to a consensus of what we want to do because we want to hear each other's opinion. Yeah.